welcome you in Anesthesia and ICU news. My name is Martin and today we will be discussing updated point of view on ketamine, as a lot of statements around this drug has changed over the last few years. Let's do not waste any more time and dive into it. Let's start with the worst, and that would be some raw attributes about ketamine. Maybe uninterested in these, but sometimes handy for examination. As anesthesiologists, we generally use around, let's say, 5 IV medication that we are using to put somebody to sleep. It can be nice that you would know some of the nuances about everyday using drug. Anyway, if you are still resisting, remember at least that ketamine has active metabolic molecule called norketamine, with about a third of the analgesic potential of the original one. Moving to the mechanism of action, this is something that you should definitely know. Ketamine is NMDA receptor antagonist. It is the only one from our anesthetic drugs that blocks the main receptors that it is working on, compared to the propofol or midazolam that are agonists on GABA receptors. Ketamine is antagonist on its main action site, NMDA receptors. This should help you that the ketamine is a little bit of different. NMDA receptors are excitatory, so by blocking them, ketamine causes inhibition. This effective site is responsible for most of the clinical effects like anesthesia, analgesia, antidepressive effect, and hallucination. But its mechanism of action is not simple and it works on multiple active sites, including opioid receptors. Data suggests that activity on opioid receptors is very likely to some extent responsible for analgesia, but definitely not fully. Worth remembering, ketamine prevents the development of tolerance to opioids and hyperalgesia caused by opioid intake. This is probably caused through NMDA action. It has effect on the serotonergic pathway, which is thought to be at least partially responsible for ketamine antidepressive effect. This effect is in terms of weeks. Fast sodium channel blockage can cause action like local anesthetics, and muscarine blockage effect can be responsible to some extent for bronchodilation and unleash of the sympathetic drive. Clinically, ketamine causes so-called dissociative anesthesia. In this state, patient can seem like he is awake. He can have open eyes, common reflexes like cough or gag reflex are preserved, but you cannot rely on this, and some patients can lose their ability of keeping their airways open. Spontaneous ventilation after induction dose commonly fade out for several seconds, but can preserve in cases of smaller doses or continuous infusion. Problems that are linked with ketamine are hallucination or feeling of dissociation. This can obviously cause discomfort for the patient. Some of these unwanted feelings can be attenuated by benzodiazepines or propofol, for example. Ketamine is a very powerful analgesic agent that alters the emotional component of the pain as well. Analgesia can be achieved by smaller doses, commonly without severely affecting the consciousness. Perioperatively, these doses can significantly decrease the opiates requirements. And now ketamine is starting to be used even in chronic pain management. Overall, it has specific use in painful situations when spontaneous breathing is desired. Ketamine has dual effect on cardiovascular system. On one side is direct cardiac depressant, but on the other side increases sympathetic drive. So because of this, you can commonly see slight increase in blood pressure or heart rate after induction with this agent in healthy patients. Situation is a little bit complicated with patients that are in shock. Imagine typical patient in hemorrhagic shock, for example, before the induction in your theater or emergency department. His blood pressure would be 100/60 and heart rate around 140, for example. You can see that this patient already has a massive sympathetic drive. He's holding his hemodynamic system on the edge of the collapse. In this situation, even when you use ketamine, you can see significant cardiovascular collapse, but it would be much less significant in comparison to the propofol, which is pure direct vasodilator and causes direct cardiac depression. To sum up this, ketamine is commonly stated as a drug of choice in shock states. It will at least partially preserve the hemodynamic status, but remember, it is not perfect and having prepared emergency medication can be definitely handy. There exist some concerns that ketamine can increase the metabolic demands of the heart and in predisposed patients can cause ischemia. Predisposition can be coronary artery disease or aortic stenosis, for example, in which tachycardia can potentially harm the heart. But there are yet no data that proves any harm in terms of mortality. Links for these studies are in description of this video. As always, feel free to have a look. Another concern that you can hear or read is increase in pulmonary pressure. There are just limited data and clinical effect is is yet undecided. To sum up these two controversial side effects, there does not exist data that proves that ketamine will do any harm or benefit in these patients. What we know for sure is that ketamine from our anesthetic options provides the most hemodynamic stable state for our shocked patients, that's for sure. Ketamine has bronchodilation effect, which is commonly used in severe refractory asthma exacerbation. Generally, you can start with so-called pain dose. Just remember, even this small dose can cause a sedation to some extent, so other sedative medication should be adjusted accordingly. With higher doses, increased secretion in bronchial tree, lacrimal gland, or salivary gland is well-known complication. If you want to prevent it, muscarine antagonists like atropine or glycopyrrolate would be your options. Ketamine was quite a while wrongly accused of producing seizures, but the opposite is true. New data shows that ketamine can and should be used in refractory status epilepticus as one of the anesthetic options. And what about traumatic brain injury and intracranial pressure? Original statement that ketamine increases intracranial pressure is mainly from studies from 70s on healthy volunteers or patients with mixed CNS pathology, but without any neurological complications reported. New data shows that effect on intracranial pressure is much more complex, can cause increase or decrease of intracranial pressure, but what was shown in all studies is that there was no negative effect on neurological outcome. Ketamine causes increase in metabolic rate of oxygen. This happens in heterogeneous way. That means that some part of CNS reacts slightly differently. Cerebral blood flow does not respond exactly the same. There is a discussion between experts about possibility for dose-dependent uncoupling mechanism. More importantly, ketamine does not affect the autoregulatory mechanism mediated by carbon dioxide of the cerebral vasculature. That means that hyperventilation and low CO2 can cause vasoconstriction of CNS vasculature. I would like to highlight the fact that patients with trauma brain injury can hypoventilate because of primary CNS injury, and if we add any kind of sedation, propofol, midazolam, whatever, they can hypoventilate even more, and this will lead to hypercapnia, vasodilation of CNS vessels, and unwanted increase of intracranial pressure. This is the situation, of course, if the patients are breathing spontaneously, and we can prevent this with mechanical ventilation. And now back to the ketamine. It is considered that ketamine has theoretical neuroprotective effect by altering glutamate neurotransmission. To sum up all what is known for sure, there is no evidence that use of ketamine can harm patients with trauma brain injury. Moreover, the beneficial effects of ketamine put it in a place where no another drug is. Its analgesic effects, together with providing hemodynamic stability, makes it a unique choice in trauma patients with trauma brain injury. And now a few notes about eyes. To unwanted effects belongs increase of intraocular pressure, which limits ketamine use in ophthalmology. And there exists characteristic side effect, lateral gaze nystagmus. It is essential that you would bear in mind that ketamine exists in two stereoisomeric forms. That's because the molecule has chiral atom. There exists an S form and the R form. The S form or the S-ketamine is one that is for our practice much more useful, has better attributes. It has greater affinity for NMDA receptors, provides approximately 3 to 4 times more potent analgesic effects, produces less cardiodepression, and carries less risk to cause hallucination. If you would like to dose S-ketamine, rule of thumb is just half your doses, and you should be okay. That means for analgesia you would be around 0.25 mg per kilogram, and for induction to general anesthesia around 1 mg per kilogram IV. Unfortunately, S-ketamine is not yet registered globally in all European countries. Final note, in somebody with renal injury, no dramatic dose reduction is usually necessary, and in severe liver dysfunction, there are no changes in the induction doses, but the maintenance dose or repeated doses should be reduced as the metabolism is primary by liver. And this would be all that you need to know about ketamine. I hope you've enjoyed this session. Leave a comment down below, I will definitely answer. And I wish you, as always, good view for intubation.